Hello, everyone, and welcome to Ortho NorCal Educational Webinar Series. We hope everyone is staying safe and healthy. My name is Leah Rutinov, and I will be the moderator for today's webinar. I'm honored to host this event together with Dr. Jeffrey Coe, spine orthopedic surgeon, and Dan Reddington, physical therapy director at Ortho NorCal. Today's webinar topic is non-surgical management of lumbar spine disorders, and it's intended for patient education only. We will have Q&A session after the presentation, so if you have any questions, please send us over to us using Q&A or chat buttons on the bottom of your screen. If you have any additional questions after the webinar, you can always email us at info@orthonorcal.com or call 408-412-8100. With all that being said, I'd like to welcome our panelists, Dr. Coe and Dan. Welcome.
Welcome. Thanks everybody for attending. I'm Dr. Coe. Sitting to my right, virtually for you, is Dan Reddington, the physical therapist here at Ortho NorCal. So we're going to break this talk essentially into three parts. I'm going to do an introduction on the impact of low back pain, basic anatomy and diagnoses. And then Dan is going to give the meat of the presentation discussing physical therapy. And then I'm going to touch briefly on some other non-surgical treatment options, and hopefully we'll have time for questions and answers. And I apologize for the technical difficulties we had getting on, running a little bit late today, and apologize for that. So the impact of low back pain. 85% of people will have low back pain or leg pain or sciatica, if you will, or at some point in your life that's often disabling. Low back pain and related disorders is responsible to 15 million office visits in the US annually. It's second only to the common cold for office visits. It's also the fifth ranked cause of hospital admission, and the annual direct and indirect costs related to the low back is $86 billion. There's evidence of strong interest about this presentation in general, the subject in general, because the registration from the webinar when I last counted was 150 plus, which is a record for the webinars we've been given here at Ortho NorCal. So brief thing on anatomy. The spine is a complex anatomical structure consisting of 24 mobile vertebrae from the base of the skull to the pelvis. These are essentially building blocks, 7 cervical, 12 thoracic, 8 lumbar vertebra, and then the sacrum is made of 5 segments that are fused, and then we even have the tailbone that has 4 little tiny segments as well, known as the coccyx. There are discs between the vertebrae that are the cushions, if you will, between the bones. They're the source of herniations at times. There's also 2 small joints between each segment. We call them facet joints because they look like the facets of a cut gemstone, but the real name is zygoapophyseal joints. So we call them facet joints because that's a big word that even physical therapists and doctors don't like to say. The spine protects the spinal nerve and spinal cord, in addition to providing structure to the human body. There are 2 spinal nerves that exit the spine at each level. And the last segment, the sacrum, connects to the pelvis through the sacroiliac joint, which is also a potential source of low back pain. We had a separate webinar just on that subject that I think might still be available on our website. The causes of back pain and sciatica include a herniated disc or a ruptured disc. There's a central nucleus part of a disc and an outer annulus. Annulus means rings, like the rings of a tree, and the disc will rupture and the disc material will come out and press on nerves of the spinal cord depending upon the level. There's a diagnosis of spinal stenosis where the spinal canal gets narrowed. This image right here shows a narrowed canal in a myelogram. You can get radicular symptoms or sciatica from that. You can get neurogenic claudication, which is the perception that you're not able to stand and walk because your legs get weak or tired or painful. Then we have scoliosis, different kinds, the idiopathic or degenerative scoliosis. The specifics of that are beyond the scope of this presentation. And then you can get fractures from significant falls and trauma, including osteoporotic fractures that can basically be what we call vertebral insufficiency fractures. That's really something that you wouldn't necessarily send somebody to therapy for. That's more of a brace and wait and then rehab afterwards. And then there's other causes like tumors and infections that are fortunately less common and pretty rare actually as causes of pain. So now here's Dan, and he's going to give us his presentation.
Thank you, Dr. Ko. And yeah, what we're going to be talking about on my side is just kind of general presentations that we see in the PT clinic and kind of general guidelines that we like to move forward on. Number one thing that I really try to stress with all my patients with low back pain is trying to move as much as possible. We sometimes have a tendency to shut everything down and try to rest too much. What that's going to do is create stiffness. Stiffness will then create more pain. The inactivity causes a decreased blood flow, will feed into that loop there. So we want to make sure that we're moving as much as possible without exacerbating those symptoms. This can be different for every person. It could be something as simple as walking, could progress to swimming, riding a bike, or even if someone's experienced in the weight room and doing a modified weightlifting program. But really trying to, again, be as active as possible while we are having these symptoms starting to come down. So when we're talking about movement, one thing that I like to really kind of focus on is movement of different spinal segments. As Dr. Ko mentioned, the spine is a very complex part of our body here, and it's made of nearly 2,000 joints. We want to make sure that those joints are able to move. A lot of times we'll see some issues where certain segments of the joint don't move at all, and then we end up putting too much strain on other segments. And we like to try to move them in unloaded positions. So positions where we don't have a whole lot of compression through the joints. This video here is going to show one of our PT techs working on a cat camel exercise where he's working on being able to mobilize through each segment here. And I'm going to get that playing for you guys. You can see where we're trying to get the spine to move in a comfortable pattern here. Big thing, again, we don't have a whole lot of weight going down on the individual segments, so we're not thinking about too much of compressive or shearing forces, more of just general joint health, being able to move a little bit. Moving forward, we look a lot at lumbopelvic position. So a lot of times we're going to see what's called the anterior tilted pelvis, where we're going to have a big curve in the lumbar spine, the low back. A lot of times these patients will complain of tightness through the hip flexors. We'll see a lot with people that are actually sitting for a long time, and we're kind of hanging on our hip flexors and hanging on our joints and extension, which can a lot of times lead to some of those spinal stenosis or facet arthropathies that Dr. Ko spoke about earlier. It's really not a super healthy position for the spine to be in as far as being able to manage and create force, because it takes out a lot of, or it results in a lot of power leaks coming from the lower body to the upper body. You can see in this picture here how we're kind of really arched in the low back, and the belt buckle is kind of pointing down towards the ground rather than straight forward. So going on to this next picture here, we want to see someone that's going to be in a little bit more of a neutral position here, where we don't have an excessive curvature in the lumbar spine. It's natural, some curvature, but we try stack a little bit more, 20% on the ground. A big thing with that is going to be strengthening the lower abdominals, which are a muscle group that a lot of times kind of gets missed with certain exercise programs and ends up giving us issues down the road. So it's a muscle group that we really want to focus on when we're working on rehab of low back pain. And I'm going to show a couple exercises that we like to use for that lower abdominal strengthening. The first one's going to be a plank. It's going to be a modified plank here, where we have our PT here getting up on forearms and knees. It's a position that most people will be able to control the spine a little bit better rather than being up on forearms and toes. A big thing you're going to see here in this video is the lumbar spine is going to be actually arched up towards the ceiling a little bit. So rather than hanging on our lumbar spine, we're having our lower abdominals actively support us. And we'll get that first video going here. And we can see that little lumbar flexion at the top there. So we really are able to dig into those lower abdominals. The next exercise here is going to be a bridge. Now, a lot of times we'll see people bridge with too much of a lumbar lordosis or curvature in their lumbar spine, and ends up causing some lumbar pain. So what we do here with our bridges, we try to get in a little bit of a posterior pelvic tilt where we can get the belt buckle going back towards the nose. It will allow us to work our lower abdominals a little bit more and really work our glute muscles, which are going to be super important. You can see this little tilt to start, and then a small lift there where we can really control the lumbar spine, and we don't have to worry about too much shearing forces through that spine there. Going forward, I touched on it a bit just before, but hip strength is going to be super important. The glute muscles are our butt muscles, for lack of a better word, kind of the powerhouse of the lower body. They're going to be providing us support for propulsion, whether it's running, jumping, that type of motion there, even walking. And really, they're going to be supportive for the lumbar spine as well. If the glute muscles are not super strong, we're going to end up relying more on those lumbar extensors, which can cause, again, more shearing forces to the lumbar spine. It can be a source of back pain. Another big part that we're going to look at is hip mobility. So a couple things that we typically see a lot is limited hip extension. So being really tight to the front of the hip. And again, that's something we'll see a lot of times with people that spend a lot of time sitting at a desk or at a computer. Ends up putting too much stress on those lumbar extensors. And we'll also see a lot of times deficits in hip internal and external rotation. So the thigh bone's ability to rotate in the joint that it sits in. And that can be especially troublesome if we're thinking about someone that is doing athletic movements, whether it's lunging, jumping, squatting. So there's a couple things that we definitely make sure that we address there to allow the person to move through a normal range of motion, be able to distribute forces in a healthy fashion. So what we like to see after we've kind of addressed those lumbopelvic stability, the hip mobility, and the hip strength and stability, is we try to progress to compound movements. Movements basically that will require a little bit of all three of those categories, and we try to get them to meld together, because it's good to be able to do something on a table, but we want to be able to do something exercise-wise that's going to carry over well to normal life here. So right here, we have one of our PTs, Brian, doing a split squat here. Split squats can be effective to strengthen the lower body while not putting too much load on the spine itself. I've got a video here. You can see in this video, there's not much movement at all at the low back. It's all lower body that's producing all the forces here. And that's typically what we want to see, whether we're working out in the gym or just kind of going through day-to-day life. We want to be able to produce most of our force and our power from our lower body. One other thing that I did want to kind of touch on a little bit as well is radicular symptoms. And Dr. Coe mentioned like the sciatica type symptoms. Those are going to take a little bit different course of rehab, where we look at trying to get into more of an extension position in the lumbar spine. A lot of times these radicular symptoms or symptoms down the leg are caused by a nerve irritation. And this is a McKenzie method exercise. Now, one thing to kind of take with this with a grain of salt is you need to make sure that the symptoms are caused by a disc injury and not a spinal stenosis. So that's where it's going to be very important for the person to actually get assessed and get a good workup before just jumping into exercises. But you'll see here with this prone press up, where we're working on trying to get more extension to the lumbar spine to kind of unweight part of the disc that may be irritated. And then we'll also see some miscellaneous factors that will lead to low back pain. Big things that we're going to see is day-to-day stress, and sometimes we'll see people with an increase in stress, whether it's from work, family, whatever it might be, and that stress can sometimes manifest as low back pain. So something to kind of take into account. On top of that, poor diet and BMI is huge. You can kind of do all the exercises, corrective exercises or training exercises that you can find, but if you're really putting really poor fuel into your body and we have a BMI or a weight that's too heavy for the spine to be able to safely manage, we're always going to be kind of limited there. So that's something you want to definitely check in on. And then another thing that we see is misconceptions about back injury and pain. Kind of touched on before how sometimes we'll get too scared to move after we've had some back pain. And that can, while we're trying to be helpful in trying to stop the exacerbating factors, can also sometimes, unfortunately, lead to worse pain down the road because of the resulting stiffness from that inactivity. So really making sure that you're discussing your back pain with a medical professional and not just kind of taking any type of advice you might be able to find on a website or from sources that may not be qualified to be able to give you that advice. So take home message from my part is number one, GGA, go get assessed. Back pain is going to have a bunch of different factors, as we already touched on. We want to make sure that to address those factors, we have the most exact exercises. We don't want to just be kind of guessing, oh, maybe this will feel good, maybe that'll feel good. So definitely want to go get assessed and make sure that your rehabilitation program is not a cookie cutter program, but it's something that's really tailored to you. And then most of all, make sure we keep moving to get out of this low back pain. I'm going to toss this back over to Dr. Ko.
All righty, thanks, Dan. That was really, really enlightening. That's a lot to take in, and I think it was excellent. And I learned something from Dan's talk. So going forward, I'm going to talk about some other non-surgical treatment options. We've already touched a little bit on physical therapy, the structured physical therapy program that's customized by Dan and his colleagues. I've found that patients that engage in yoga and Pilates, that both include stretching, aerobic exercise, and core exercises is very important. I'm a big believer in aerobic exercise of some type. It's good for cardiovascular conditioning, good for endorphins, and helps all sorts of aches and pains. And Dan, of course, emphasized the core, then the hip flexibility. Something I learned is that, yeah, those that spend a lot of time sitting in front of their computer, well, I guess get hip flexion contractures and lose some of their hip extension, which puts a lot of stress on the lumbar spine. Medications do play a role in the treatment of back pain. That includes a non-steroidal anti-inflammatory class for those that can tolerate it. Some patients can't tolerate it, and some patients find a significant benefit from it. Muscle relaxants are used on a limited basis. Narcotics has been prescribed, but I say avoid opiates and narcotics. I think it's something you want to try to avoid doing because it can be a very slippery slope for a variety of reasons. It's very easy to get hooked on this. There was a New England Journal of Medicine article that came out years ago. It was actually a letter to the editor that basically claimed that if you used opiates for real pain as opposed to taking it to quote get high end quote, that you don't get addicted, which turns out not to be true. Very, very high performing athletes, for example, Brett Favre of the Green Bay Packers, have been hooked on these things to treat their sports injuries. So don't think that you cannot get addicted to opiates just because there's something magical about your personality, your life, or something like that. We're potentially all susceptible to that. So we like to try to use opiates in my practice, at least, for basically the immediate post-surgical discomfort. The neuropathic medications like Lyrica and Neurontin can play a big role for those that have, in particular, a burning nerve pain. It can be even beneficial for the pure axial back pain. These medications have variable levels of tolerance and variable levels of dosing, so all that has to be individualized between you and your medical practitioner. Now, spinal injections we'll touch on in a few extra slides, will have both a diagnostic value in that they'll help your physician understand the real source of your pain, and they can have a therapeutic value to give you relief that is hopefully at least short-term, if not long-term. And then there's this alternative medicines like chiropractic and acupuncture that many patients have seen benefit from. The chiropractors will often do adjustments. They'll do, non-manipulative therapy that may be of benefit for some patients. What is one thing that I would avoid with chiropractic? There is and you'll see ads in the newspaper for these types of machines that are essentially expensive traction machines, although the chiropractors that use these will say they're not, but they're very expensive. They're not covered by insurance. I tend to avoid those. If you want to try traction, you can do there's chiropractors that will do something called flexion distraction. And then you can, on yourself, you can go buy on Amazon for like $125 an inversion table, which helps stretches out the spine. And I've had many patients that like that. I'm not endorsing it necessarily, but I'm saying that's something some people have tried. And acupuncture is a type of pain treatment that doesn't involve drugs. It's very helpful. It's very, very impressive. They're very good acupuncturists in our area, that if that's something you would like to do. There's some of us to treat our pain, we have to modify our activities to a certain extent. Doesn't mean don't move. It means that you have to find different ways of moving around and different ways to accommodate your disability or your impairment. And another thing is weight loss. We as society, despite COVID, we still are managing to eat. We may even be less active, and having a high BMI is significant. Imagine if you already have back pain and you try to go on a 2 or 3 mile hike with a 30-pound backpack. That's going to hurt like a lot. And just imagine if you are out there and you're overweight. Imagine what it'd be like to take that 30-pound backpack off that you really is in the fat cells of your body. So you really want to get that off your body if you can. So let's talk about epidural steroid injections. There's a lot of misconceptions about what these are. Some people call them epidermal, which is on the skin, but epidural is the target of the injection. It's next to the dura, which is the covering of the spinal nerves, and can be done translaminar, which is straight from the back, or transforaminal, which is from the holes where the nerves exit that I discussed earlier. And the transforaminals can be a little bit more targeted. They're more for the lumbar spine, although there's some that will do it in the cervical spine or the neck. But the translaminar is generally what's done in the cervical spine and the thoracic spine, because you have to worry about the spinal cord and the blood vessels that feed that. In the lumbar spine, that's below the blood vessels. Sometimes a selective nerve root block is considered equivalent or close to that of a transforaminal. There's another type of injection that's caudal, that's done like up through the tailbone area, the sacrum, in the midline in that direction. That's not done very often, at least in my experience these days. And some particularly the ladies in the audience will get confused because they had an epidural to have childbirth, for example. Well, that epidural injection was accessed to deliver a local anesthetic for anesthesia. So the target was the same, but the medication this was different. So the steroid is a medication that relieves inflammation. Relief from epidurals can be short-term or long-term. The example shown in the picture here is that of a herniated disc that inflames the nerve. And so the space for the nerve becomes even less than required because the nerve swells. That's part of inflammation, is swelling. So when the steroid is on that, you don't change the space available for the nerve. It's not going to change the anatomy of the disc, but it'll allow the nerve swelling to go down, and in some cases get you back to your baseline before the herniation, or in some cases the stenosis or the narrowing. And maybe the disc will shrink a little bit with time and heal. So it expedites your recovery in that way. There's actually one study that shows that for herniated lumbar discs in patients that are hurting so badly that they would really consider surgery, 50% of them may avoid surgery with the epidural. So a lot of misconception about epidural. Is not just a Band-Aid. It has value because it can allow you to get rehabilitated. For example, go see Dan, get through physical therapy, so that you can actually do all those exercises and those wonderful videos he showed, and tolerate it better without the inflammation. So other types of injections include injections of the facet, the small spinal joints that can be intra-articular into the joint, usually with a steroid, sort of like how you would do for a knee or a hip. That's not typically done that much, but it can be. I'll sometimes do that in the upper cervical spine because there's a certain type of arthritis that if you can block that, and you'll sometimes use a local anesthetic just to make sure that you're in the right spot. That can be treated with a particular type of targeted surgery for that. The medial branch block is really more of a diagnostic test. It's generally not with steroid. It numbs the nerves to the facets and gives you an idea about whether or not there's other interventions like radiofrequency ablation. Radiofrequency ablation is a form of using a type of electrical current to burn or temporarily destroy the nerves, sensory nerves that innervate the facet joint. They're very targeted. It's very safe. It's similar to what I as a surgeon use in surgery as electrocautery to kind of the cut tissue. But this has a prospect of giving you 6 to 12 months of relief if you have facet-mediated pain. And then we talk on this on a separate seminar that if you have potential sacroiliac joint pain as a source of your low back pain, you can have injections to either treat or diagnose that. a pure anesthetic injection. If it really knocks out the pain, you know that the sacroiliac joint is the source of the pain, with the understanding that you're only getting a few hours of relief. The whole point is to see if that's the source of the pain or not. With the steroid, you hope to get a little bit longer relief. So I want to give a Leah, can you hear us?
I can hear you now, but I had trouble hearing you a few minutes.
How far do I need to go back?
I think you stopped at Dr. Malumphy when you were introducing Dr. Malumphy.
Okay, so, all right, so I understand we had technical glitch there. Can you hear me now, Leah?
Yes.
So Dr. Malumphy is our spinal injection specialist. She does a fantastic job of injections, and some of you may have already had a chance to meet her or been treated by her. She will do many of these injections in the lumbar spine in our Los Gatos office. So the take-home message, part 2. Low back pain can have many causes or contributing factors. Rehabilitation needs to be tailored to every individual. After you visit Dan and undergo physical therapy, you want to continue with your core strengthening, your stretching, and your aerobic conditioning. You want to get your weight down and keep it off. Ideally, you want to have a BMI of under 30, a body mass index. And if you don't know what that is, just take your height and take your weight, put it in a little online calculator, just Google BMI, and you can figure out what your BMI is. And you want to get that under 30. Many of you that have been overweight for a long period of time, if you can get it down to 35, that would be very helpful as well.
Dr. Cole, I hate to interrupt, but your slides are not showing. You have to share
Oh,
your
I have to
screen.
reshare again?
Yes,
Oh, I'm
please.
sorry. Hang on a
That's
second.
okay.
How do I, let me just get out of the presentation mode and redo this.
Okay.
Let me hear. Okay, share screen. All right, let's share. Oh, can you see it now?
Yes.
All right, so, okay, so let's go back here. So you heard what I said, BMI 30 and keep it off.
That's
I've already,
correct.
let me go back and introduce you again, Dr. Malumphy. That's, she's fantastic. So you want to stay active, consider intervention, medications, injections when needed, stay active, and as Dan says, keep moving. So thank you for watching, and we're now open for questions. And Leah, you're going to moderate those. Is that correct?
That's correct. Yes. Thank you so much, Dr. Ko and Dan. Great presentation. And we do have questions to start off. The first question is, my chiro says I have DDD. He suggested glucosamine and fish oil. What are your thoughts on supplements?
All right. So that's a complicated question for 2 reasons. So what is DDD? DDD literally means degenerative disc disease. Well, that means as you get older, 100% of us develop this disease. Well, disc degeneration is part of natural aging. It's like the wrinkles in the skin and the your gray hair, or in my case, your hair falling out. It's part of natural aging. So what makes it a degenerative disc, a disease disc? Well, it's when it's symptomatic, when it causes pain. Well, how do you know when it causes pain? Well, because the patient tells you and you see an MRI that shows a disc degeneration. That may or may not be true. So it's kind of a diagnosis of elimination, in where you see an MRI or an X-ray that shows something that looks like degeneration, and the patient has pain in that area, and you say, well, yeah, that's maybe a source of pain. We actually used to do a test called a discogram, where we actually put a needle in a degenerated disc that we thought was painful and another disc that we thought was not. And we pressurized it, injected, and the patient was awake, and they would scream and yell, says, yeah, that's it. And then on the basis of that, we would treat that disc. For various reasons, we very rarely do that study right now. But the bottom line is, yes, you can have discogenic pain. The characteristics of discogenic pain that's not related necessarily a herniation, or say a herniation that's not putting pressure on the nerve, is you have increased pain with sitting, and you get some relief from standing or lying down. In terms of the supplements, there's probably very little harm to taking glucosamine. What was the other medication that was asked in the question, Leah?
Give me
Fish
one.
oil. Yeah.
Fish oil, that's correct.
Yeah, fish oil. Yeah. You know, I don't know that there's any scientific benefit to that. It may have a placebo effect, and if you believe it to be true, and you're invested in it from an emotional, psychological point of view, you probably will see some benefit from it. And I'm not denigrating placebo. Placebo can be a good thing for some people. But that being said, you know, the glucosamine are some of the building blocks. There's not a lot of scientific evidence on how it works by taking it orally for the spine, but some people swear by it. And it may be a placebo, it may be not, but it's very little harm, and it's potentially worth doing. But the whole issue of disc degeneration as a cause of pain is a kind of a conundrum for us.
Thank you, Dr.
Does
Ko.
that help?
Yes, absolutely. So that answers the question fully, I believe. So the next question, if somebody is not responding to Neurontin, does that indicate what the issue might be?
Not necessarily. And Neurontin, especially generically known as gabapentin, is a medication that has a huge therapeutic range. Some patients will have a good therapeutic effect or even side effects from 100 milligrams, which is 0.1 gram. Some patients, it's like taking a sugar pill when they take 36 times that amount, or 3.6 grams. So it's a medication that has to be titrated. If you've ever done a chemistry lab where you sort of put drops of a chemical in a test tube and see it change color, we kind of have to do something like that with the human body with certain medications. Titrate it to effect. In other words, are you getting a therapeutic effect or a benefit at a certain dose, or you're getting side effects before you get a therapeutic effect? And those of you that have been my patient or have been on gabapentin before will know that that drug has to be adjusted. It's less so with Lyrica. But the bottom line is, non-response to gabapentin is relatively meaningless. For the most part, it can have some value if you had responded in the past and you're not responding now. But the answer to that question most of the time is no.
Thank you, Dr. Ko. This question is for Dan. Is squatting or deadlifting bad for my back?
Sure, yeah. So squatting, deadlifting, we do occasionally see back injuries that result from that, but typically it's not because of the exercise itself. It's because the person was either not prepared for the exercise, so they were lacking certain stability or mobility at different joints, or they're performing the exercise incorrectly, or kind of like Dr. Ko was talking about with dosage with medication, there needs to be correct dosage with exercise as well, as far as the amount of resistance, sets and reps, that type of stuff. So at a base level, squats and deadlifts can be very, very beneficial for developing core, lower body, and back strength. Big thing with those exercises, you want to make sure that the mechanics are correct, the form is correct, and the dosage is correct.
Thanks, Dan. Next question, I guess, for both. I'm wondering why back spasms happen. What triggers them? Why the muscles won't release? Why is it so painful? And why does it not allow you to stand up straight? Once this happens to you, what are the best solutions to get rid of the back problems, and how to prevent them from coming back in the future?
You know, that is an excellent question, and one that I try to explain to my patients in the office, and I'm glad to have an opportunity to explain at least my concept of why people get back spasms. Basically, when you have an inflamed condition or an injury to the spine, the body's response is to fire nerves almost reflexively, in fact, we call it reflex spasm when it's a true spasm, to stabilize the spine, to hold it still, because in this particular case, the body perceives motion as being harmful and dangerous. And so the nerves, the muscle nerves to the paraspinous muscles fire, and you can't get them to stop firing. For example, to see if a spasm's truly reflex or not, I'll have a patient side bend and rotate and see if there's anything I can do to get the muscles to relax. And so it's the spasm itself is painful, but it's the lesser of two evils, according to your hindbrain, that's not really thinking about it. It's just kind of reacting. And so your body is tightening that area up so it doesn't move. And sometimes if somebody has a disc herniation sciatica down one leg, say the left leg, that you'll see spasm and the body will be kind of tilted to the opposite side to take pressure off that nerve. All of this is kind of a reflex. Or you can't tilt backwards because you can't extend because it puts pressure on the nerve. In fact, that's one of the things, a little test of the McKenzie is if you can't tolerate extension, that's not a good prognostic sign for getting better with non-surgical treatment, at least non-interventional treatment, like a steroid might help in that case. The best way to treat it, if you will, is to try to treat the underlying condition with the anti-inflammatories and a little bit of rest, and then the judicious use of therapy. And there's therapeutic modalities that Dan will touch on. I find that ice is very helpful for acute spasm. In some cases, we'll use that class of drugs known as muscle relaxants, which most of them really kind of are weak muscle relaxants and more sedatives, and help you sleep and things like that. But they do have some degree of muscle relaxing effect. Sometimes spinal injections, if you have trigger points are a little area of localized muscle spasm, and that just don't go away, and they're kind of in a reflex arc. And if you just numb it up, and even though the numbing medicine will last just an hour or two, or in some cases with long acting several hours, it'll actually break the cycle and break the spasm permanently, at least for that episode. So that's my answer to the question. Dan, you have anything to add?
Sure. Yeah. Just kind of piggybacking on some of those strategies that we use to address the muscle spasm. Something else to think about is some breathing exercises. When we have these muscle spasms, typically we're going to be in what's considered a sympathetic state, which is our kind of fight or flight state, where everything's going to be kind of locked up and really tight. So if you can start working on some just gentle diaphragmatic breathing, typically patients will respond to that pretty well because we're not moving the joint too much. But we're actually trying to get our sympathetic state to switch to a parasympathetic state, which is more of our rest and digest. And typically that can kind of help us get over that hump a little bit to allow you to move a little bit more after that, and then kind of continually address those spasms going forward.
Great question. Anything else, Leah?
Yes, oh, plenty. So the next question, any advice on sleep positions? I find it difficult to find a position where I don't get some form of symptom, mostly tingling.
Well, that's going to really depend upon the reason why you have the tingling. In some cases, the tingling isn't spinal. It could be a peripheral neuropathy. There's this so-called restless leg syndrome that sometimes patients will have some tingling with that. You kind of need an assessment and a diagnosis to understand that. In general, I find that patients will find they have acute, subacute, in some cases chronic low back pain, don't tolerate the supine positioning very well unless they have pillows under their legs, so they can try that. There are some patients with spondylolisthesis that find that their legs will go numb or tingle if their head is propped and not if it's flat, or even vice versa. It all depends upon what you tolerate. Side lying is actually very good for most patients because you can adjust your legs to any position that's comfortable for you. Whether you're aware of it or not, everyone changes sleeping. Some are prone sleepers or belly sleepers, but most of us will roll around in bed a little as we sleep to one side or the other and not wake for that. The important thing is to get sleep. Find a position that works for you and get to sleep. Sleep hygiene is very, very important for general, particularly chronic pain, because if you don't get good, it's a problem. One of the reasons why sleep properly, and I personally had this problem, is sleep apnea. If you're actually not breathing for various reasons, see a sleep specialist, possibly get a sleep study and get treated for sleep apnea, because that can be a very big deal. It can be a source of weight gain. It can be a source of back pain. So if you have undiagnosed sleep apnea, that's something that basically you should address. I hope that helps. Dan, do you have anything?
No, I agree with all of the above. One other note that I'd make is, as Dr. Coe said, the side sleepers typically can do pretty well. Another thing that can kind of help with that side sleeping is if you roll up a pillow and put it in between the knees there, it'll take a little pressure off of the hip, and sometimes can be even a little bit more comfortable to sleep.
Next question.
Next question. Hi, Dr. Coe and Dan. Can you give a little more info on ideal BMI? Through good diet and Peloton bike, I have been able to get to 178 pounds and at 6 feet height, which equates to approximately 24.1 BMI. Some BMI calculators state that 25 BMI plus is considered overweight.
Well, that's an excellent question. And BMI is an extraordinarily crude calculation, and it's almost biblical in how it's being used to assess weight in a way that I think is unfair to individuals. For example, if you are, let's say, an ex-professional football player and you have had a lot of muscle mass, having a BMI under 30 is not realistic. Right. If you're, there are many of us that have BMIs between 25 and 30, even though that's technically considered overweight, that aren't really overweight, and it's not really much of an issue. And some patients over 30, individuals over 30, that's considered obese. And then you add on top of that, not only your morphology, whether you're a mesomorph or an ectomorph or an endomorph, you add, for example, spinal deformity. And let's say that you have a scoliosis or a kyphosis, or if you had compression fractures and you've lost 2 or 3 inches of height, all of a sudden, you're losing out on the number that helps you. Being taller allows you to be heavier. And so now that you're shorter, I've always thought that maybe BMI should be calculated on driver's license weight, because, a driver's license height rather than your actual measured height, because that's what your height was at an ideal time in your life. But BMI is relatively crude, and I'm not absolute about it. I agree that I think being considered overweight just because your BMI is 25.2 is a little bit much for most of us, but that's the numbers that's in the literature, and that's kind of what we have to deal with.
Yeah, I think with BMI, I think you have a better idea when we're thinking about the 30 plus. But as Dr. Coe said, if someone's got a heavy muscle bulk and they're not super tall, that BMI might be kind of misleading there. Another way to measure that is percent body fat. So percent body fat you want to see for females somewhere in the 20s, low to mid 20s. For males, probably closer to 15 to 18. So that's another way to be a little bit more exact.
Yeah. I think that's probably a better measurement, but it's also a harder one to do. It requires more extensive testing, and with an observation, and there's a little bit of expertise required to measure it. Is it still measured with the triceps? How do you measure that these days?
So there are different machines, and some are a little bit more reliable than the others, but there are different kind of body scan machines that are going to take pressure, be able to measure pressure from the hands and feet and give you a decent idea of where the percent body fat is.
Because they used to use a tricep skin fold test. That's no longer used?
No, that one's not used too much.
See, that's how old I am. That's an obsolete test. Well, that was a great question. We're getting some great questions today.
Some really good questions coming in. The next question, is there anything you can do to rebuild disc height?
To rebuild disc height?
That's correct.
Oh, well, the short answer is yes, with surgery. But most people, and this is a non-surgical presentation, in certain cases in the cervical spine, if you've lost disc height and you've got pressure on nerves, and this is kind of, you'll disc herniations and the like will, we'll do disc replacement so you can stay mobile in disc fragments. Sometimes it requires a space or an infusion, and we use these things for that. Short of surgery, there are some thoughts that, and this is getting into this kind of sketchy area of regenerative medicine that you'll see a lot of publicity about, where stem cells, so-called stem cells, and usually it's bone marrow aspirate, which have some progenitor cells that can be considered stem cells. You inject that into the disc and you'll see reversal of some changes of degeneration. I think really, first of all, none of this is endorsed, certainly by the FDA per se. There haven't been really good randomized clinical studies. That being said, there are some patients that have value with that. Most of the time, the disc height is not built back up, but it's probably an anti-inflammatory effect. If you use an inversion table or some type of flexion, distraction, or traction, you can improve your disc height temporarily. But loss of disc height is natural with aging. If you have a disc herniation, then the disc material pops out into the canal. And whether you have surgery or not, it's not ever going to go back into the disc space. So you lose disc height from that. And there are many, many, many patients, in fact, perhaps all of us, if we are lucky enough to live old enough, that our disc heights are going to go down. That's one of the reasons why we lose height when we age, is because of disc height loss. It may be the primary reason for most of us. So rebuilding disc height as an actual therapeutic goal by itself is not something that I would really strive for. I would strive, for, fix the things we can fix. We can fix our strength. We can fix our joint mobility. We can fix the load on our spine. We can fix our cardiovascular conditioning. So I wouldn't focus on disc height per se, because really, short of surgery, there's not much you can do about it.
Thank you, Dr. Ko. Next question. Do you have a program on scoliosis? I have 2 curves in my back.
I don't hear the question. What's the question?
The question
do
is,
we have a program on
program on
scoliosis?
scoliosis, yes.
Yeah. Our program on scoliosis basically consists of doing an evaluation and understanding what the structural issues are and the potential pitfalls are, the progression, the degree of pain and discomfort that's potentially caused by it, and then going through a rehabilitation program to include, physical therapy. If it's a young child, then bracing is a potential option. And for an adult, bracing is an option not to correct the scoliosis long-term necessarily, or you can do that in an adolescent or a juvenile, but it can be it's a special type of brace available. It's called the Aspen Peak orthosis, that in some cases for adult spinal deformity can give relief of pain. I hope that helps.
Thank you, Dr. Ko. The next question. Does pain in the hip, top of leg radiate from lumbar disorders?
The short answer is yes, is a definitive maybe. It can. There's a lot of overlap between the hip and the spine. In fact, a friend and colleague of mine, Dave Polly, who's an academic spine surgeon in Minneapolis, and an ex-Army guy like myself, basically coined the term the hip spine syndrome. And one of the things I've found is that people will think that they have quote unquote hip joint pain, end quote, when it's actually coming from their spine. They perceive it in their buttock or lateral hip, where most hip joint pain is typically felt in the knee, in the front of the thigh, and I'm sorry, the groin and in the front of the thigh, and sometimes the knee. And sometimes it's only in the knee, and that's kind of referred pain. So our perception of pain and the location of pain is sometimes very misleading. The reality is that spinal stenosis or disc herniations in the mid to upper lumbar spine can overlap with the perception of hip pain. And so this is one of the things that's part of the assessment, to understand, is it coming from your hip joint, from the trochanteric bursa on the outside, or your lumbar spine or sacroiliac joint? All this kind of thing is all overlapped. And that's why this is not a question I can answer for any individual without an individualized assessment. It includes examination and the appropriate imaging studies. Dan, anything to add to that?
No, yeah, just as Dr. Ko said, the spine and the hip are going to have a strong relationship together. So like you said, sometimes we have hip pain that's originating from the spine, but really without a full assessment, can't give a definitive answer.
I'm going to say one thing though. If you've been told by your hip specialist that you need a hip replacement, and it's credible, you believe them, and by your spine specialist that you may also need spine surgery, which one would you do first? Well, in general, in part for what Dan said before about hip flexibility and stress on the spine, I would get the hip done first. And the reason being is there are many examples that I've known in both my personal life and my practice that fixing the hip obviates the need for spine surgery. You get enough relief of your spinal pain from restoring the mobility from your arthritic hip that the spine, the spine pain, the lumbar pain is no longer a surgical problem. And yeah, that gives me less business. On the other hand, it's better for my patients. Because arthritic hip pain is not just about the with walking, it's also about your ability to be mobile and to be active and to move. And so in some cases, in fact, I would say most cases, about 95% of the time, I would if you have to have both things fixed, I would get the hip fixed first and then take care of the spine down the line.
Thank you,
Lee,
Dr.
anything else?
Yes, there is one more question, and looks like that would be it. So the last question is, I would love to have you address the use of ice versus heat and the advisability of using CBD products.
Great question. I'm gonna let Dan answer that
Can answer
first,
that,
and I'm gonna chime in at the end. All right, Dan, you go ahead first.
Yeah, when I think about ice versus heat, I think it's going to be really individualized. Some people are going to respond better to ice. Some people are going to respond better to heat. While they can have some effect on blood flow, really, whether it's ice or heat, it's more of an analgesic or pain desensitizing effect. So it's really going to be depend on either. Although Dr. Coe did make a good point earlier that a lot of times muscle spasms will respond very well to ice. But again, it's one of those things where if you're having a lot of back pain, choose one of those, either ice or heat, see how it feels. If it doesn't feel great, choose the other one. You can kind of do a little experiment there on your own. You're not going to cause any damage with either one. As far as the CBD, I know I've heard anecdotally people have good responses to it. I'm not aware of the research on it, so I can't speak too strongly to that. But also, Dr. Coe mentioned before, if you feel like something's going to be really effective and you believe that that can have a very powerful effect on how you perceive pain. So I'll kick it back to Dr. Coe.
All right. In terms of the muscle spasm, I think Dan's spot on. Basically, acute problems, muscle spasm, ice is great for swelling and things like that. That's kind of traditional. When we talk about extremity injuries, we have this acronym RICE, which is rest. What is it? Rest. The I is ice, and the C is the compression, and E is elevation. It's kind of hard to elevate your back, but you certainly can ice it. It's hard to compress your back, but you can get a brace to do that. But the point is, ice is kind of considered more for the acute. But the long term, whatever works, heck, alternate it. The one thing I will warn you about ice doesn't apply so much to the back, but there are professional athletes, including professional basketball players, that have had a knee injury, and they put the ice on their knee. On the outside, there's kind of a nerve called the peroneal nerve. And there are athletes that have actually killed their nerve and had permanent paralysis for putting ice in that position. So you want to be really, really careful with ice on certain parts of your body. But on the back, for the most part, I've seen, some people get burns and things like that if, kind of skin changes if they have ice or even heat on too long. So the key is use it judiciously, alternate, see what works for you. The answer is it's empiric. Empiric is a fancy medical word that basically means trial or error. So in terms of the CBD, CBD is the non-hallucinogenic component associated with marijuana. It is available legally in California. It's a little bit sketchy in terms of the federal regulations on it. But that being said, there are a lot of vendors for CBD. Its efficacy is not been studied in a rigorous scientific method. On the other hand, there are many people that I know that swear by the use of CBD when used judiciously. And I've even tried it myself. I have no idea if it really works or not because you just don't know. But the point is, it's not likely to harm you and it can be taken orally. It can be put on as a balm or an ointment. And so not that I'm necessarily endorsing it, but it's something that I think is not likely to do you harm and may be of some benefit. It is fairly expensive in its current formulations. But that being said, if you get it from a credible vendor and you try it and it works, more power to you.
Great, thank you so
Anything
much.
else?
Yeah, no, I think that's all. And thank you, Dr. Cohen, and thank you all for joining us today.